go ahead and get started. Again, good morning, good afternoon to everybody. I'm Gail Iwamasa. I am the chair of APA's Division 18 VA section, and I'd like to welcome you to today's webinar. As you can see on the screen, Psychological Practice with Transgender and Gender Nonconforming Service Members and Veterans. Just want to say thank you ahead of time to Dr. Jacob Eleazer, who is our presenter today, and remind folks that today's webinar is sponsored by the VA section of APA's Division 18, Psychologists in Public Service. For those of you who don't know about Division 18, we are the home for VA psychologists within APA, so as well as other public service psychologists. For example, those who work in community agencies or state facilities, in Indian country, the criminal justice system, and police and public safety. So we hope that if you are not a member of Division 18, you'll consider joining. We'll post our website into the chat at some point during the conference. One of the great things about being a Division 18 member is that you can get free CEUs for attending our webinar series, including today. Before we get started, just want to let you know all questions could please be entered into the chat box. We will try to do our best to respond to technical questions as they come up. And Dr. Eleazer will try to have time at the end to respond to any specific questions about his presentation. So we'll try and get to those at the end. So without further pause, I'd like to just introduce you all to Dr. Jacob Eleazer. He served in the Army National Guard for 12 years and was among the first actively serving transgender soldiers to come out publicly in 2014. He advocates for access to care for transgender military personnel as the Director of Advocacy for SPARTA, a professional association for transgender service members. Very clever. Jake completed his doctorate in counseling psychology at the University of Louisville in 2019. He is currently an advanced postdoctoral fellow in HSR&D at the VA Connecticut Healthcare System and Yale School of Medicine. He is a member of the PRIDE Cohort Research Lab within PRIME, which stands for Pain Research, Informatics, Multimorbidities, and Education, the Center of Innovation. So without further ado, take it away, please, Dr. Eleazer.
Thanks so much. And just let me know if you all have any trouble hearing me. You know, some of it might be text, some of it might be my horrendous accent from Kentucky. So just let me know if you're having difficulty there. My name is Jake Eleazer. I use he, him pronouns. I'm a queer trans man and served in the Kentucky Army National Guard. I come to this this work both as a clinician, well, as a clinician, as a researcher, and as somebody who has lived experience as a transgender person in the military. I want us to start out with a little bit of a get to know you, which I know is nigh on impossible in these webinar type settings. But if you're comfortable and you're out there and you're actively serving or you're a veteran, if you could maybe test out the chat for me and let me know what branch you are in or served in the past. All right, Navy. All right, fantastic. And I'll also ask, and no pressure for anybody to out themselves or anything like that, but if we've got any LGBT, queer, trans folks that want to give a shout out, please feel free to do so too. And to those folks, I would also say just thanks so much for helping queer this professional space with me today. All right, love it. I love that. All right, and feel free to also just let us all know what setting you're working in. Are you working in the VA? Are you working in DoD? Community mental health? What type of agency are you working in? Love it. Awesome. American Lake. All right, I got a shout out there. That's where I did my internship. All right, thank you all for doing that, and I love to see how many people are out here from all over the place. It really is just beautiful to see. So thank you for being here. I'm going to start off as with any DoD VA type training with a disclaimer about how the opinions expressed in this presentation are completely my own. It does not represent the official position of the Department of Defense, the Army, the National Guard, the Department of Veterans Affairs. I am just speaking for myself here. Also, the artwork and photographs, I just want to give a shout out to Jeff Sheng, who took most of the photographs that are used here in this presentation, and a thank you to the transgender service members and veterans who have allowed me to use their images for this presentation. I think it adds context for folks to actually see what transgender service members and veterans look like, and I think but it's also a risk for these folks too. So I just wanted to express my appreciation to the community members who have allowed me to do that. So our agenda for today, we're going to talk a little bit about transgender military service, the history, the policy context, and a little bit about my own lived experience and what that was like for me. We're going to talk about the impact of those experiences or those realities on healthcare and access to care for folks. We're going to talk about being a trans-affirming provider, and I'm going to give you some resources and tips and strategies for how to help practice with cultural humility and how to leverage the resilience of the transgender community when you're providing care. I also want to just mention here that this workshop, this training is about you, and I'm flexible. So, you know, as we go through here, I may spend a little bit more time on some things, not as much time on other things. You may see me flipping through slides if it looks like we don't have enough time. I really want to make sure that we leave some space at the end for questions. So if there's anything that you feel like we didn't quite get to or we missed or that you'd like to hear more about, I am absolutely available and willing to help. Just please feel free to reach out. I'll drop my email address at the end of the presentation, both in the slides and in the chat. Feel free to reach out anytime. I also just want to give another briefer disclaimer that I am going to share with you part of my own story, and I want everybody here to know that this is a safe place for curiosity. I really genuinely want your questions. And I think a lot of times people fear that they might come across as offensive, or they might accidentally phrase their question in a way that they didn't intend. I want to make this as open as possible. And if you do say something that's offensive, I'm going to let you know. If you ask a question I don't feel comfortable answering, I'll say no, but also that's okay. And I want to normalize that process. Again, I'm not going to cover everything. We've got an hour, less than that now, and so this is going to be an inch deep and a mile wide. So please, please, please reach out if you have other questions after the end of the training today. All right, so transgender service members and veterans, this is where I'm going to spend the bulk of our time today, because I think the most important things that folks have a good understanding of what it's like to serve as a transgender person, what it's like, the experiences of transgender veterans, and what that actual lived experience is like. Here's the brief timeline. So the first important thing to know is that Don't Ask, Don't Tell did not cover trans folks. When the Don't Ask, Don't Tell repeal was initiated in 2010, implemented in 2011, transgender people were not covered in that policy change, even though transgender people were often pursued under the Don't Ask, Don't Tell policy and previous homosexual exclusion policies. This particular policy change, while a landmark policy change for LGBTQ service members, did not include the trans community. There was a period of time before 2015, where transgender folks were sort of in this liminal space where folks in military leadership positions weren't quite aware that there was a distinction between trans and LGBT folks, and where people were starting to pursue transition more publicly. Not to say that that hadn't been done in the past, but that this was becoming more of a visible issue, both within the military and within our national mainstream media in the United States. And then the period of time between 2015 and 2017, we saw a more concerted advocacy fight for open transgender military service. So in 2015, we saw a halt of discharges by each of the military branches starting in the spring of that year. So Army, Navy, Marine Corps, um, Air Force all issued policy statements saying that, okay, we're going to look at this policy. So while we're looking at this policy, we're going to stop the discharges for these actively serving trans folks. That summer, there was an announcement by the Secretary of Defense, Ashton Carter, saying, we're going to research this policy. So he formed a working group, and that working group was going to take a year to interview people, do data collection. They commissioned the RAND Corporation to do a huge study. If you're one of those research nerds out there like me, it is out there publicly available, all of the numbers. And then in the summer of 2016, they actually announced the new policy with a year timeline for the rollout of the policy change. Then there was an election, and in 2017, a new administration came in. The policy was still moving forward. However, they had not implemented the part of the policy that would allow transgender people to join the military at that point. And then later that year, there was some tweets, an announcement, a policy change, and then in 2019, that policy actually went into effect. So I'm going to get into this stuff in a little bit more detail, but that's just kind of like the overarching broad strokes, what this experience has been like for trans folks who have served during this time period. A lot of back and forth. Anytime I'm talking about trans military service, I try to make it clear that this is not a new issue. I think because a lot of folks feel like this is new to them, that it's just new in general. That is not the case. Even within the narrow cultural context of the Western world and the United States, right? And even within the narrower lens of the United States military. So here I have Private Albert Cashier. He enlisted in the 95th Illinois Infantry during the Civil War in 1862. We can't really make claims about how people might have identified, right? Because the term transgender is one that was sort of introduced by the medical field after the lifetime of Private Cashier. But I think it's notable that Private Cashier, even after the end of the war, continued to live his life as a male and was not outed until he was hospitalized in 1914 by his doctors. And at that point, he was stripped of his pension and prosecuted for impersonating a soldier. And then more notorious is Christine Jorgensen, who was drafted in the U.S. Army during World War II in 1947. She was the first person in the United States to pursue gender-affirming surgery and come out publicly about that. And so it hit the headlines at the time period in a very sensationalized way. So I say all this just to reiterate, this is not new, and we've been here since the beginning. Broad strokes about the population. So this is a 2014 study based on data from, I believe, the 2010 version of the National Center for Transgender Equality's survey of U.S. transgender people. And from those data, they found that around 148,000 transgender people were actively serving or had served in the military. Of those, around 134,300 were veterans or folks who were inactive in the Guard and Reserve. And then around 15,500, remember, this is when trans people weren't supposed to be serving at all, were serving active duty, active Guard and Reserve components. All right, so to get into some of the more nuts and bolts about the policy history, again, not covered by Don't Ask, Don't Tell repeal. Don't Ask, Don't Tell was enacted by Congress. It was legislation, and there was a legislative route to get that policy changed. That was not the case for the policies banning transgender people from openly serving. Those were really encoded most prominently in the medical and mental health regulations, military regulations, and then also in our criminal case law and the Uniform Code of Military Justice. And so those were the two primary paths that folks were discharged. So one was through medical mental health regulations, the other criminalization of gender identity and policing of gender conformity, not just policing as in getting, experiencing microaggressions, but direct policies specifically saying you cannot perform your gender outside of your assigned role. So things like grooming and uniform regulations. I think even, just throw back to the wax and waves and all those folks, things like you must wear a brassiere and you must, women can't be smoking on the streets and all sorts of things like that. So there's a pretty long tradition of gender policing and military regulations. Pathologization of gender. All right, so the regulation where this is kind of most prominent is DoD Instruction 6130.03, and then its corollary 6130.04. And those policies list the disqualifying conditions which preclude military service, and then also the military standards for retention. And so this is how those regulations are broken down, what they actually read in the policies at the time. So any history of major abnormalities or defects of the genitalia, including but not limited to change of sex. And then here's the one where we are implicated as professionals is paragraph 29, item R, current or history of psychosexual conditions, including but not limited to transsexualism, exhibitionism, transvestitism, voyeurism, and other paraphilias. And just for context, again, we did this, right? And I think that's important to note our own role as mental health professionals in the systemic oppression of the trans military community, because this maps right onto the DSM-3 language. And the language still read that way up until this policy change in 2015, 2016 timeframe. So that was us. Criminalization. I'm not going to go through all of these, but these are the different types of articles in the Uniform Code of Military Justice, which is the military's legal code, that have been used to discharge transgender people. They fall into two main categories. One, non-judicial punishment, right? And non-judicial punishment is a type of punishment that can be directed and adjudicated at the command level. So your company commanders, your battery commanders, all those folks, they have a very broad latitude to, I won't say arbitrarily, but kind of at their discretion, charge people with different infractions of regulation and punish them based on that. This could be things like extra duty, demotions. There's just a whole list of different things that can happen to folks via non-judicial punishment. I think overarchingly, the thing to understand is even though there are some limits, as those aren't criminal offenses, it can really kill your career. Punitive articles were the more dangerous ones that could actually end in jail time for folks. So things like fraudulent enlistment if they thought you had known that you were trans when you signed up. Failure to obey an order. So if somebody orders you to cut your hair and you don't do it, they'll get you. False statements. If you're taking medications from a non-military provider and don't report that on federal documentation for your annual physical, they'll get you for that. Taking controlled substances, sodomy, routinely applied to transgender women in particular, very disproportionately. Conduct unbecoming an officer, and the general article, which is the military's favorite catch-all for we got you for something, but we don't know what. All right, and I'm going to stop here, and I'm going to tell you a little bit about my own experiences with this process. So you can take this as my bias statement, or you can just, again, just speaking for myself here. So in March 6, 2015, I was studying for comprehensive exams, like you do, and I got knock at the door. I get up, I go and I answer the door, and there's a postal worker standing there, has a certified letter for me. So I was like, okay, this is interesting. So I took it and I opened it up, and here's what it said as this letter, but really poor image of a letter that you're seeing here. It says, a review of your Army medical records by the appropriate Department of Army authority shows that you no longer meet the Army medical standards for retention based on your current medical condition of gender identity disorder in accordance with Army Regulation 40-501, Chapter 3-35, Alpha and Bravo Standards of Medical Fitness. For me, this letter was the end of a 1.5-year battle for me to stay in the military and retain my commission as an officer. As assigned female at birth, I grew up in the rural South. It was very challenging for me to come to terms with my gender identity, coming from a very strict religious background. The harder choice for me was deciding what I was going to do about that. I was in the military. I knew that coming out was would end my career, pursuing transition would end my career. I had initially enlisted in 2006 as part of the 617th Military Police Company, and had been identifying openly as not openly, but I identified as a lesbian at the time. And so I felt like I had an understanding of what it was like to serve as an LGBT person based on that experience of identifying as a lesbian and serving under the Don't Ask, Don't Tell policy. In 2009, I commissioned as an officer, started my service in the 138th Fires Brigade. And then in 2012, two major things happened. I got accepted into a doctoral program in counseling psychology, and I started a new position as what we call a TAG officer, which is a teach, assess, and counsel officer, who's in charge of basically a drill sergeant for officer candidates program. So new soldiers or soldiers who had been enlisted would come into this training program, and we would create a high stress environment for them. And then at the end of it, they would be commissioned officers if they made it through, which is a big if. Typically, we'd start off with around 76, 78 soldiers and commission about 12 of them. And so I had started coming out and coming to terms with my trans identity in 2010. I had several periods of time where I had started my transition process and then realized, oh wait, I can't do this. This isn't covered by Don't Ask, Don't Tell, and then I'd stopped. And then at some point I decided, okay, it's like I got to move forward with this, and I thought I got it. I know how to live like this. I can figure it out. It's called compartmentalization. When I'm in uniform, I am a straight lady, and when I'm not in uniform, I'll be on campus living my life as Jake, and that'll be fine, right? It was not like Don't Ask, Don't Tell. As it turns out, things change when you start hormones. My voice started to drop. My body was starting to change and in different ways, and because of the program that I was in and the work that I was doing there, these things just started coming up where my worlds were starting to collide. I volunteered to be part of a statewide suicide prevention advocacy group. Showed up and met all of the people in the room and introduced myself as Jake with my tie on. I thought I was fancy. And then found out at the end of the meeting, somebody was like, oh, by the way, our colleagues at the Kentucky National Guard weren't able to make it today, but they'll be here for next meeting. And I had to go around that room and beg each one of those professionals who I was trying to network with to pretend they had never met me. And it was completely humiliating. The period of time I was stationed out in Western Kentucky, so I would drive out to my duty station from Louisville, where I was going to school, and I would, it was a 2-3 hour drive. I would have to stop at some point to use the restroom a lot of times, and it ended up getting more and more and more pressure because I would go into the women's restroom and had people pull me out. Like physically pulled me out of the restroom. I've had the cops called on me. I thought, well, this isn't working. So I thought, well, maybe I'll just use the men's room and nobody will notice. But then I had a situation where I was walking into the men's room and my commander was walking out. And so that was awkward. I had to like pretend I was an idiot or something. I was just walking into the wrong room. And so kind of these sorts of things kept cropping up. And I realized, okay, this is just not going to be tenable. So I made the decision that I was going to get out. We had just commissioned a new class of soldiers. I thought, okay, well, I wrapped up with that cycle of trainees. It's time for me to just saunter on out of here. And I showed up to drill. We had a brand new class of candidates, and they showed up in formation, and I saw in that formation locked eyes with someone I also knew to be transgender. And that really shook me. I thought I can't just resign and get out of here. Part of my oath and my commitment as a military leader to my soldiers is leaving the organization better than I found it, and it just felt like it would be a cowardly, a very cowardly thing to do to just leave, to just resign. So I decided, okay, well, I know they're going to kick me out, but I'm planning on getting out anyway, so I'm not losing anything here. So I came out to my commander, who was, my immediate commander, who was she was a badass. First female company commander of MP company in the state, and umpteen deployments. She was just super squared away and supportive. But she was confused. She didn't realize that Don't Ask, Don't Tell didn't cover trans folks, and so she thought it was going to be fine. I had battle buddies that I worked with there. I obviously was not fooling anybody. I was looking pretty butch. So when I told them, they were like, "Oh, I reckon that makes sense," And I think that it was always an open secret. They would have us. We have the new candidates come in, and then it was always the funny thing because they always had to salute. And they would say, "Ma'am, Officer Candidate Smith," and then they could say whatever they were going to say. But if they couldn't get those first 4 words out of their mouth, they were going to be doing push-ups. So it was always the funny thing where they would come in and they would salute me for the first time and they would say, "Sir," and then my buddies would just come in and get in their face, pull out the knife hand, and be like, "Does Captain Eleazer look like a man to you?" And they would get really confused. It would be, everybody would laugh because I did. I looked like a man. And so this was just kind of like the running gag. And so it really wasn't a shock to anybody, I don't think, when I came out. The problem was not the people that I worked with. It was not my soldiers. It was not even my immediate leadership team. It was the chain of command and the people who didn't know me, who all they knew about me was the paperwork that was coming out. I got pulled out in the middle of a field training exercise and was told that I needed to go pack my gear. I was leaving. So even though we were not in a position to be down a staff member, just pulled me right out of training. My senior NCO, bless him, came up to me and pulled my jacket sleeve and said, "Hey, ma'am, I didn't know you were resigning." And I was like, I didn't know I was resigning either. And apparently they had submitted a resignation on my behalf without my consent, without my signature. And when I called them on it, they were like, "Well, this is going to be the outcome of it anyway, so you better just let it go." They then sent me to a medical evaluation where they said my eyesight was deteriorating and attempted to falsify paperwork in that way to get me pushed out. They sent me for a psychological evaluation at Fort Knox, where I was doing my practicum. So that was funny. And then they finally figured out, okay, this is the right way to actually discharge this person, and went to pursue the administrative discharge process. I'm telling you all this stuff not just because it's just fun to talk about, but I think it's really, really important to understand how these systemic things, which often feel vague and remote, right, have a very direct lived experience, impact on folks' lived experiences on the day-to-day. I'm glad that I came out. I was in a very uniquely privileged position as somebody who had training in Army human resources. I knew the regulations and I knew what they could and couldn't get me with. I had connections to lawyers through my work with Sparta. I had training as a mental health professional, so when they sat me down to do my psychological evaluation, I, could say, "Hey, give me your license number." I know that's like not how you want to start a relationship with somebody, but I knew what was right, and I knew that I was going to be in a position where I could push things. I was in the reserves. I didn't have a family that was relying on my paycheck. Um, and I was a high performer. And so they couldn't get me for things like, being outside of regs for my physical fitness or for my duty performance, which had been stellar up to that point. So that's when things got really weird. Through Sparta, we were able to do some advocacy work. We went to the White House, we went to the Hill, we went and talked to folks actually in the Pentagon about our experiences. And that I love this like picture at the bottom left here. That's me and my buddy in the men's room at the Pentagon before that was legal. So it was, maybe someone will arrest me one day, but maybe not today. And then there was victory, right? Secretary Carter says, our mission is to defend this country, and we don't want barriers unrelated to a person's qualification to serve, preventing us from recruiting or retaining that soldier, sailor, airman, or Marine who can best accomplish the mission. And so it was victory. And that was the day I got that knock on the door when that Alarak came out. And just 3 hours later, I got a call from my friend Brent Tannehill, and she was like, Jake, it's over. And I thought, oh, she knows. Somebody told her what happened with me, and she knows that my career's over. And I was like, I know it's over. And she's like, no, it's over. The Army just issued policy stopping discharges. So I got to stay in by the skin of my teeth. And then things happened. There was an election. There were some tweets. I'm not going to rehash that too much. But I think the piece that I want to leave you all with in the context of my story and these experiences is that in the absence of clear policy, right, as these policies were changing back and forth, the folks who served during this time period, the confusion allowed people to do what they wanted and command and interpret policy in the ways that they wanted. I think one service member told me it felt like it was open season. And in that particular context, lacking clear policy, prejudice reigns, right? And so these experiences, while my experiences as a white, transmasculine, binary identified person, had this narrative where I survived this experience. Many of my colleagues did not. So, current policy. I'm not going to get into details about minority stress theory just because we're running low on time. It's the basic idea here, right, is that distal stressors and proximal stressors lead to poor health and mental health outcomes for folks. Distal stressors being things that happen externally, and proximal stressors being things that happen internally or under the skin. And those things function together, right, to produce additional stressors for folks, which then lead to healthcare disparities. And it's basically a long, fancy psychological theory for something that folks in oppressed communities have known for a long time, which is basically that if people treat you like crap, you're going to feel like crap. Right? And then the thing that doesn't really get highlighted enough here is resilience, right? Community connectedness, pride, healthy coping strategies, social support, all of those things can disrupt that pathway, right? From distal stressors to poor health and mental health outcomes for folks. I think that's important to remember. So this is the current policy implemented in 2019. We've got folks who are exempt from the policy and folks who are not exempt. Exempt people if they had a gender dysphoria diagnosis in their military medical record before 11:59 p.m. on April 11, 2019, they're allowed to continue to serve and they're allowed to access care. We think we caught maybe about 1,500 of our folks who were able to meet this criteria. Everybody else is not exempt. They have to serve in their gender assigned at birth. New applicants or recruits must have 36 months stability in their sex assigned at birth, right? So if you've started transition, if you're still identifying as trans, if you have a gender dysphoria diagnosis, it's just a no-go. So new applicant, so those folks can't have transition, they can't have received gender affirming hormone therapy or any sort of surgery. Again, I'm not going to get too much into detail with this, but I want to share with you some quotes from my dissertation study, which was a qualitative project on the experiences of actively serving transgender military personnel. These were some of the themes that came up when I asked folks about their experiences accessing care. So fear, right? So one sailor said, I was afraid to go to a therapist because the military, and several times I made phone calls and talked about making appointments and stuff like that, but I never went because I knew it would mean the end of my military career. I knew it would mean the end of my marriage, and I knew it would mean the end of my life. There was also themes around barriers to competent care. So folks would try to go in to see a provider and they might have experience in working with military and veteran populations, but they wouldn't have any experience working with trans folks. Or they would find a gender affirming provider who wouldn't know jack about military service or soldiers. And so a lot of times folks were getting caught in this trap where there really wasn't any one provider who was competent to address the complexity of what they were experiencing, their presenting concerns were. And overall experiences with providers, some of them were really great and some of them were pretty bad. One soldier said, I knew that I needed help, so I called the Veterans Crisis Line. The guy I talked to was a retired chaplain. He told me that I was harming my wife and children and that God would not forgive me. This is the suicide crisis line, by the way. Another soldier said that when I mentioned that I thought my depression was related to being trans, the doctor said, we don't treat that in the Army, and if I mentioned it again, he'd have to tell my commander. And then the tagline for this presentation, another soldier said, it's kind of sad to say, but I'm afraid of my therapist. And these experiences were also directly, or these service members also talked about their therapists reporting them. So most of the folks that I interviewed were not out, had not come out to providers, but two folks did come out to their providers and were in the process of being discharged for the interview between the time I recruited them and the time the interview was conducted. And so when one Marine was saying the behavioral health social worker was a Navy commander, she was sympathetic, but she had to do her duty, and I understand why she had to tell. And I elicited this response when I was asking her about positive experiences with health providers. I think that's interesting about. This is the VA directive, very different, right? So for those of you all who are in the VA, I think it's good to be familiar with VHA Directive 1341 on its second edition right now. We cover just about everything with the exception of surgical procedures. So that's mental health services. A lot of VAs have support groups. If you're curious to know if your local VA has a support group, there is a link on the VA's LGBT patient care services website that'll let you know. We offer letter writing for safe passage letters, hormone therapy, and gender affirming surgical referrals. Hormone therapy, a wide range of prosthetics, which vets are always surprised by. Speech therapy, hair removal, pre and post-operative care. And then care coordination. Every VA facility is supposed to have an LGBT veteran care coordinator, and you can also look at your local VA's website, and it should be listed on there who the point of contact is for those services. I'm not going to get into the stats here, but I think I just want to note that those experiences are also some of those negative experiences that we talked about in the context of actively serving folks have also been reflected in the experiences of veterans. As much as we have affirming policy and we have a lot of strategies implemented in the VA to make sure that folks are getting adequate and welcoming and affirming care. That's not always folks' experiences, and historically hasn't been. And so I think the one that I think is most important to be mindful of is that this recent study by Lehavout and colleagues, fear of disrespect or discrimination from healthcare providers caused transgender nonconforming veterans to delay seeking healthcare at a rate of 31%, and mental health care at a rate of 22%. Right? And that's a scary thing to think about when we also consider that transgender and gender nonconforming veterans are at a higher risk of suicide. Again, because we're running low on time, I'm not going to get into all of the details of the different guidelines. I think it's important to be aware of the WPATH standards of care. There's also a set of guidelines on how to clinically appropriately conduct gender affirming treatment in primary care settings at the National Center for Transgender Excellence. And so if you need links to those resources, again, they're all available online for free. I'm happy to share them with you. These are the main roles that WPATH outlines, though, for us as mental health providers. Access, or assessing people, so whatever assessments are needed to make sure that they're getting their insurance coverage for their care and that they're getting appropriately referred to providers who are able to do prescriptions and perform surgeries if that's part of the veteran's treatment plan or the individual's treatment plan. Care, right? Providing that direct care in a gender affirming way. And I think it's important to note, providing care specifically related to somebody's gender identity process. And, trans people come in for other reasons too. And so not funneling towards the action, right? Or engaging in voyeurism there, right? So we want to make sure that trans people have safe and affirming places to access mental health services for all of the reasons or all the presenting concerns that might bring them in our door. And to educate. Right? So it's not good enough for us to just do our jobs, right? We have to also make sure that we're pushing the systems that we work in and our community of professionals to do better. Again, these are APA guidelines available for free online. I'm not going to go into every single one of them because I do want to make sure that we hold some time for questions here. I think particularly guidelines 1 through 7 are really important for folks who are doing that, who are direct practitioners working with individual and group and couples therapy settings. And overall, I think I think what will really sort of move folks beyond I want to be helpful to an actually being helpful state is really practicing cultural humility. So it's one approach for minimizing the impact of implicit biases on clinical practice, right? It reflects an other-oriented stance marked by openness, curiosity, a lack of arrogance, and a genuine desire to understand clients' cultural identities. And with that are cultural opportunities, right? So opportunities that clients will sometimes give us to directly engage in a conversation about their cultural identity. And so those are moments when there's an opportunity to directly attend to that patient's culture or client's cultural identity. If you're wanting to kind of do some self-reflection, it can be helpful to ask yourself, am I curious about my client? What assumptions am I making about my client based on their presentation or based on their stated identities? Am I avoiding topics or discussions connected to my client's identity? And again, this is by no means comprehensive, but I think these are really great questions to get you started thinking and engaged in that reflexive practice. Helpful tips. Clients always the expert on their identity. Ask them how they identify and what their identity terms mean to them, right? So you might have 15 different people who say I'm a trans FTM person, like that's how I would describe my identity, right? And each one of those people is going to mean something different. So it's important to kind of ask those follow-up questions and really get some insight into that individual client's identity process and what that identity is to them. Reflect that person's language back to them, right? So if they describe their genitalia as a penis, say penis. If they describe their genitalia as something else, use that language, right? Especially when we're talking about folks' identities, their bodies, and their relationships. Know that trans folks seek therapy or medical care for issues that are completely unrelated to their sexual health or gender identity. If you're ever curious to know about how this can have really life-threatening implications for trans folks, you can Google the term trans broken arm syndrome. It's scary, right? So we want to make sure as providers we're not sensationalizing folks' identities. We're attending to them, but we're not sensationalizing them. Don't make assumptions about a client's gender based on their appearance. So this goes to doing asking about pronouns, asking about gender identity, asking about sexual orientation, routinely every single time, because you don't know the answer till you ask. Everyone makes mistakes. Right? It's important that we as providers own our mistakes and communicate a commitment to change both verbally and through our behavior. I think a lot of times for me as a trans person, I get caught in this trap where I think, oh, I got it. And as it turns out, I don't got it all the time, even when it comes just to gender identity issues, right? So I think it's very important for us to both repair those ruptures when they happen and model for our patients how to appropriately own our mistakes. And then learn to recognize and engage in those cultural opportunities when they emerge in session. I'm not going to get into the claim model. Happy to send you a copy of this, but this is just one strategy for apologizing when somebody calls you in or when you recognize that you put your foot in your mouth and you've done jacked up and you need to do something about it. I keep this on the wall behind my patients so that I know exactly what I need to do when I find myself in one of those moments. And as providers, always, always, always leverage trans resilience. Trans folks are survivors. They draw power from their community. It is just an incredible, incredible resource. And so I think a lot of times as medical and mental health providers, there's a lot of narratives in our literature and in our publications about trans suffering. And while I think it's important to be aware of the healthcare disparities and the mental health disparities that impact our community, we also need to look at trans power and trans resilience too, because these are the tools that are going to help us actually heal folks. And so just from my data, from the data I collected, I had an officer saying, being a member of an online support group saved my life. I don't know where I'd be if it weren't for the support I found, and the support group probably dead. It was also really therapeutic to have someone ask, this soldier was talking about his identity, and be able to tell them. And so allowing people to bring their whole selves into the room it can be a really powerful thing. Here are some different places where different organizations, nonprofit organizations that address the needs of transgender service members and veterans that could be important to get in contact with. I have a full resource list. Again, I'm happy to share this out. If there's a way to kind of send an email to everybody in that's attending the training, or if we can post this, or feel free to send me your email address. That's my contact, so feel free to send me an email directly, and I will do anything and everything I can to get some resources to you if you want them. And with that said, I will give you, just 10 minutes for questions. What have you all got? So I see a comment here from Jamie about hair removal being for genital hair only. Actually, it's not. We just got at VA Connecticut approved for facial hair removal for a veteran. So I'm in a statement I think just came out from LGBT Patient Services on this as well. So I'm happy to send all of the resources that we use to make that happen. I really want everybody to be doing this. I think it's super important for the health and welfare, particularly of trans folks who facial hair causes a lot of dysphoria, and so yeah, we need to be doing this. This is our job. So there are a lot of spaces where where folks are facing resistance, and sometimes this is held at the local VA level, and there may be more or less support for that work. But again, I'm happy to help provide resources and support for advocating for that change. I think it's super important.
So, hey, Jake, it's Gail. Can you hear me?
Yeah.
All right, super. So the great news is if you just send it to Tiffany, she can blast it out to everybody who's registered for the webinar. So you don't have to worry about
Awesome.
being inundated with email, although you
Sorry,
did
y'all are going to get spammed.
address up there and you invited people to email you. So I guarantee you probably will be getting some email directly, but just so that all the attendees know, we will make sure that we'll get Dr. Eleazer's resources to everyone who's registered. So you can rest assured that you will have that. Jake, I don't know if you see, there is one Q&A that is there from Ayane Ferguson. I'm not sure if you can pull that up on your end. If not, I could read it out loud. One of the questions that came up when I was working for the U.S. Army was about the APFT.
Mm-hmm.
The main issue was that, and this was in 2013 to 15, so it could
Yeah.
be changed. Someone who is transitioning from female to male would be at an unfair advantage because they were being tested against female criteria.
Yeah. So here, I have a couple of thoughts on that. One is the APFT isn't a competition. I know that a lot of units do incentives and we have awards that can sometimes be associated with that. But ultimately, the APFT is designed to make sure that you're meeting those meeting military readiness standards. And so we're in a position now where we're moving towards MOS-based physical fitness standards, and I think that's the way to go, right? Because I think a lot of times we get kind of caught up into this mindset that it's about competition. Really, it's just about, can you do your job? The other thing I would say too is that the military came out with a very clear policy on how those situations would be adjudicated, and it comes down to the change in the gender marker administratively. Now, I can't say that I necessarily agreed with the determination that they made, but there was a policy that was issued out there for how they were going to manage those situations. We know from research that's been done in competitive sports, transgender people in competitive sports, that it's that the testosterone that really differentiates, accounts for the variance there, right, in performance. And I say performance, but performance in certain specific things, right? So typically when somebody's been on hormone therapy for a couple of years, their performance mirrors the I hesitate to even say target gender, right? Because this is also a very kind of binary way of looking at sports and performance. But yeah, I don't know. I mean, I guess those are kind of my broad thoughts on that. It's just that kind of conceptualization isn't really necessarily supported by the literature. And the Army policy or the military policy in general wasn't necessarily mapped onto that particular research either. But in 2013, it was a free-for-all, right? There was no policy, there was no guidance. So I can understand why it got very confusing and people were uncertain about what to do with that. Yeah.
Thank you. We probably have time for one more quick question if anybody wants to type quickly into the chat. While people are thinking about perhaps a final question, just want to thank you for sharing your story. I don't know if you had a chance to look at the chat while you were talking, probably not, but lots of shouts out and appreciation from participants for you sharing your personal story and recognition that that was difficult. And so a lot of appreciation and of your courageousness of sharing that with us today.
Yeah,
So
I appreciate that. And I think it's important.
Yep,
Yeah,
still coming in. Oh, we got one last question. If you wouldn't mind taking that one. Oh, it keeps moving, so I will try to do this.
I got it. Yeah. So
Okay,
first of all, I would just say that I appreciate that sentiment, and my story is one of many. If you're curious to hear more about transgender service members and their lived experiences, check out Sparta's website. It's got a section there called Commitment to Serve, where it highlights the lived experiences of a number of transgender people who are still serving in the military today. I would also invite you to check out Transmilitary, which is a documentary film done, really headed up by director Fiona Dawson, who looked at, followed the stories of several transgender service members before the policy was changed. So if you're kind of curious about what folks' experiences were like in that time, it's a great place to learn more. For Jasper, your question, unfortunately, I only had 2 folks in my sample who identified as non-binary. Those folks also identified as F to M, and so it was, it was very challenging, I think, to make any sort of well, I mean, it's qualitative. It was an IPA design, so I'm not really able to make generalizable statements about folks' experiences. I will say for those 2 participants, there were some feelings of hope about potential policy change, but also disappointment too, because they, I think, had an understanding that even if the policy was changed, that it was going to be changed in a way that really privileged binary identified folks, right? And that's how the policy came out, and that's how it's written. And so I think there was also some resentment and some I won't say resentment, but just some sadness there too for folks about that. I think in particular in these policies that are coming out in the workplace, they're very tailored to folks who have binary identity experiences, and that sort of linear type of a transition process. And so I hope that's something that we're able to continue working on in the future and military policy and making space for folks in that way. But that's just not the case right now, and it's pretty sad to think about.
All right, thank you so much, Dr. Eleazer. We're going to have to let that be the last word. Thank you again so much for sharing valuable resources, information, your courageous story, truly an inspiration. And we're very fortunate to have you in VA, pushing forward research and really continuing this conversation, which is a challenging and difficult one for us in VA, but is so needed. Just want to let you all know, those of you who are interested in getting continuing education credit, I posted the link to an evaluation that does need to be completed by next Monday, September 7th. You all will be getting an email, everyone who's registered for the webinar, to remind you about this. If you're not a Division 18 member, you can still receive CEUs for this presentation by going to the Division 18 PayPal account. Again, that information will be provided to you in the follow-up email. All right, thank you so much, Dr. Eleazer, for your amazing presentation. Thanks to all of you who attended, and we'll see you next time on the Division 18 VA section webinar. Thanks, everyone. Bye-bye.